Basically, you have a choice for, in my field, office-based rhinology, and for many other fields in urology and in GI where they're doing scopes, you essentially have a choice presently without the use of the LOA. You can provide a general anesthetic, and that means the person's going to have to go to like a hospital or an ambulatory surgery center, and the fields are all moving into minimally invasive office procedures. If you do take it to the office, minimally invasive procedure, you have to have a patient that's either too awake and may have recollection and discomfort associated with whatever you're doing, or you get them deep enough that they're going to oxygenate poorly and their airway is going to be difficult to manage because you don't have anything to be able to handle the airway if you get them deep. The LOA changes that because it enables you to be able to give them a good strong dose. In fact, they can even be apneic, which means lose their respiratory drive at induction for a minute, 2 minutes, 3 minutes, 4 minutes, sometimes longer, depending on how thin and healthy the person is. And it delivers oxygen so well that their oxygen saturation will stay up. Still at 98%, even though she's apneic? That's just that jet ventilation going on with the airway. Will you let me know, Jim, when you think she's had her first breath? And when they begin to resume their normal respiratory drive, at that time, it ventilates so well and measures that CO2 exhalation that you have that comfort, that early comfort that they're beginning to breathe well and they're breathing effectively. Initially, when I tried to do cases just using an oral airway, it did help keep the airway open. Thank you. But it just in no possible way could deliver the oxygen as effectively. Jenna's just telling me right now she just had her first breath. So even with that extended period of apnea, her saturations were maintained beautifully the entire time with that high flow oxygen being delivered immediately above the glottis. It's essentially functioning kind of like jet ventilation. Boise, we're seeing our first CO2 waveform. It really is not just good at delivering the oxygen effectively, but you get very early and accurate measurement of the capnography. So you can feel comfortable if you're starting to see some desaturation, that not just that they're making respiratory effort, but that it's effective respiratory effort by seeing the capnography very early. And that's because the airway is sitting immediately above the glottis. Again, just like a closed circuit LMA, but without the contact with the glottis. Throughout that case now, because you have the LOA, you don't have to use large boluses of medicine anymore because the airway itself is not stimulating. So you can go about your business and handle the case. I'll give an example. Like in my field, we do a lot of intranasal sinus procedures using a balloon. And I have many colleagues around the country that are trying to do those procedures. And it'll take them an hour, 2 hours. The person's hurting. Their memory of it is not favorable. It's difficult for them to get the procedure accomplished fully because there's areas that have too much discomfort associated with it. It really generally ends up being a negative. In our patients, we can accomplish all of that in 15 minutes because at induction, they're completely out. They don't remember anything. The airway itself is not stimulating. They're deep enough that I can make them super numb. The airway not being stimulating and they're very numb means that little boluses of anesthetic are needed. I can do everything perfectly because I don't have to concern about them having any discomfort associated with it or any limitations in what I'm doing. In 15 minutes, they wake up, everything's completely fixed the way it's supposed to be, and the sedation wears off rapidly and they're able to go home 15 minutes later. Going from 2 hours and I hated that to 15 minutes and I don't remember it and I feel great is a game changer.